going online?
You're online?
Wait, just a second.
Yeah.
Yeah.
Good evening, friends. Welcome to Indian Arthroscopy Society webinar today. It's webinar number 117. We have an interesting topic which we talk about combination of a cuff tear and instability. Something which is quite challenging regarding decision making and treatment protocols for all of us as shoulder surgeon and shoulder arthroscopy surgeons. Dr. Bhuvan Machani is here with us. He's an expert into it. He's an upper leg extremity surgeon at Burjeel Hospital for Advanced Surgery, Dubai, UAE. Thank you, Karthik, for arranging this webinar for Indian Arthroscopy Society. We would be enlightened by Dr. Bachani on this interesting topic. A slight twist into the lecture as well. Dr. Machani has a patient today also, which he did with cuff tear with instability. And I think this will give us a different perspective to the webinar today, the way he is going to start our webinar today. Karthik, if you can briefly introduce our guest faculty to all our members, and then Dr. Machani can share his screen and start his presentation.
So thank you, IPS sir, and thank you, Sarnavidesa, for all the efforts, academic efforts. Dr. Bhuvan Machani, I guess he requires no introduction. He's one of the renowned faculties across the globe. He's been a consultant in the UK, Birmingham, for more than 15 years, and he has been in service in UK for more than 21 years. He's a consultant specialized in the field of upper limb surgery, especially with shoulder and elbow. For the last, after being there in UK for 20-25 years, he's recently has shifted to UK and has been attached to one of the prestigious hospitals in the region of UAE, Burjeel Hospital. I welcome you, sir. Thank you for accepting our invitation and hand it over to you.
Thank you so much, Karthik. And IPS, it sounds like IAS Oberoi or IPS Oberoi. It's funny. It's a great name. I wish I had something like that. IPS Machani.
It's just the names, nothing more.
Good. So I have a lovely friend or a patient. It's a Stephanus. He's 27 years, and I'll just briefly explain about the history. I'll examine him, and then I'll let him go. And after that, I will share my screen with the presentation, if that's okay with you. Yeah. So I will just turn the screen around towards the patient, and I will stand up and do some examination with some questions. Yeah. I hope you can see. Stephanus, if you can just stand up for us. Can you see us?
Yeah.
Perfect. That's good. So this is Stephanus. He's 27. He's right-hand dominant. He's part-time banker, but mainly plays rugby and other sports. And that's very typical of UAE, where we get a lot of sports injuries. He had recurrent dislocation for last 6 years, but the last one was in summer, in July, where he dislocated whilst doing weights. And at that time, the pain was different. It was not just pain, but he had increasing weakness as well, which was uncommon, which was different to his previous dislocations. So the MRI scan did confirm Banker's lesion with heel sacs. The glenoid itself was fine. There was no major bone insufficiency, but he had obvious supraspinatus tear, which obviously explains why he had a different type of follow-up after this recent dislocation. So he underwent surgery, arthroscopic cuff repair and stabilization at the same time, and that was end of August now. So September, October, November, December, it's about 3.5 months. So how's the recovery been, Stephanus, for you?
Well, at first I was extremely scared. I was always very scared of surgery, but now I'm able to do everything. I've started a small gym program along with my physio and guidance from yourself.
So you said you were able to do only 60 kilo push-ups?
At the moment, yes. So I'm bench pressing 60 kilograms on the barbell and a bit lighter on dumbbells.
So we agreed that he's going to get back to rugby in 4 weeks' time. But I'll just show his range of movements, obviously. Just turn towards me. Or maybe this way. Good. So the operated side is the left shoulder. I examine the right shoulder. He has external rotation of almost 80 degrees. And on the right shoulder, this is now 3.5 months. He has maybe 70 degrees or so far. and take movements forward all the way up, all the way up. So you can say pretty good for this period of the time, and sidewards that way, all the way, all the way. That's good. Bring it down. Fantastic. And how far can you reach it back? Fantastic. And then if I just assess closed can for supraspinatus, push me out. That's pretty good. And relax. Keep it there. And push me out. Very good. And turning. Elbow forwards. Push me out. Very good. So all the external rotation in neutral was 70. In abduction, it's pretty neutral, pretty normal there. Yeah. And then any pain when it press like this, absolutely stable there. Just checking for overhands as well, push me up, and pretty normal there. So I think you can call this as a good outcome. And I mean, he's quite happy, so am I. So I have given him a green signal to go ahead for the rugby in 4 weeks' time. Stefan, thank you so much.
Thank you so much, Dr. Magician. Thank you very much.
Thank you.
Thank you.
So that's just the background of what it is. I'm just going to share the screen and then give some highlights or insight into why this is a different situation. Yeah. So can you see the slide okay?
Yeah, it's perfect.
Okay. So it's not a different ball game. I think it just creates different, a perspective of what exactly do you have to do. And this is not uncommon. We do face these situations quite frequently in the clinical settings. Something's happening now. So although it's basic, we should always go back to think about what are the stabilizers. And we all know it's a static and dynamic stabilizers. Static stabilizers are the congruence of the glenohumeral joint itself, the version of the humeral head neck to the glenoid, the capsule and the ligaments, mainly MGHL and IGHL, but the glenoid labrum. Although the labrum deepens the socket to 50%, but it actually contributes to only 20% of the stability for the glenohumeral joint. The dynamic stabilizers are rotator cuff, biceps tendon, but more than that, it's proprioception. It's what your mind tells and what your mind feels. The rotator cuff, it produces the compression forces, and hence the conformity is increased. The coordinated contractions, they produce a steering effect, keeps the glenoid into the socket or ball into the socket. Dynamization, and it's more important than the static stabilizer. So these three questions, I think if you're able to get answers for these three questions at the end of this talk, I think I've done my job in here. So when should a rotator cuff tear be suspected after a dislocation? So do you suspect dislocation in every patient who comes with a dislocation? Whether you treat them operatively or not operatively, and who do better? And finally, when you do decide to do surgery, do you treat them individually, like do you repair only the cuff or the labral repair, or you do both together at the same time? I think these are the three questions which should be a take-home message today. So is there evidence? Unfortunately, there isn't a great lot of evidence in the literature. One cadaveric study, the 50% decrease in rotator cuff activity resulted in 50% increase in the occurrence of dislocations in all positions. You just take off a bit of rotator cuff in the cadaver, and then you try and move the shoulder joint in different positions, and there's increase in 50% of dislocations. Additionally, in somebody who has a rotator cuff tear in cadaveric study, you just need a minimal injury to dislocate the shoulder. What it tells us that rotator cuff does give enough stability. And don't forget, the overall incidence of rotator cuff tears increases with age, the incidence being between 7 and 32%. And anyone who is presenting dislocation middle-aged or elderly, we always suspect that. Another study, it is research showing that The primary concern is recurrence after any anti-dislocation surgery, and patient showed decreased pain and improved function after surgery as compared to those who treated non-operatively. 84% of the patients did better with surgery as compared to only 50% who were treated non-operatively. Further evidence shows that patients who underwent rotator cuff repair and stabilization at the same time in 90 patients, most of them did well except one risk of or one recurrence. So I think this is what we come across daily. It is very difficult to pick up or standardize a treatment for all the age group and all the clinical scenarios. I think if we go by clinical scenarios one by one, I think that should tell us what exactly should be done. So should you always do MRI scan in every patient who comes with a dislocation? Patients with shoulder dislocation with tuberosity fractures, what do you do to those patients? What do you do in patients who present with acute cuff tear and first-time dislocators? What do you do in patients with acute cuff tear with recurrent dislocation, like the patient who we saw just now? What do you do in patients with chronic cuff tear and coming with any acute or chronic dislocations? And what do you do in patients with combined injuries in presence of nerve injuries? So I think these are pretty much the most of the clinical scenarios. There might be other, but this is a general or common clinical scenarios we come across. So if you take one by one, so should you always do MRI scan after dislocation? The answer is no. I mean, obviously you don't do MRI scan in every patient. You do a plain X-rays, which shows a decently well-reduced glenohumeral joint, no major heel sacs, and no bony Bankart pathologies. Then you don't need to do them MRI scan. Because quite possibly, it's not possible to do MRI scan, CT scan in every patient. I know it's not available. It's resources, cost of the scans, they're not possible. What do you do? Like everyone else, brief period of immobilization, and then you follow them up. That's most important. You follow them up in a few weeks' time. You reassess it. If stable, but patient still has pain, and then you suspect there is a weakness in the supraspinatus, then you have to do an investigation. But in patients who are not so young, especially in the middle age and recurrent dislocations, I think I would always do an MRI scan or MRI arthrogram, and you do consider CT scan with a subtracted humeral head for the glenoid index as well. So yes, MRI scan is not necessary in all the patients, but on follow-up, if you have weakness and patients who have recurrent dislocations and in middle-aged patients, I would have a very, very low threshold to obtain imaging on these patients. Patients with greater tuberosity fractures, don't get confused with the heel sacs fragment. They're two different scenarios. If anatomically reduced, make sure you see them in a week's time. And if it is continuing to be undisplaced, you can treat non-operatively. Any displacement of more than 4 millimeters in young fit patients, that's my cutoff. Please obtain CT scan and MRI scan and treat accordingly. If the tuberosity fragment is very tiny, I actually am more concerned in those patients because they're usually an avulsion, supraspinatus tendon injuries. Then you suspect that there is a tear, obtain MRI scan and treat accordingly. So there is a debate whether to fix the tuberosity alone or to treat the labral repair at the same time. I think my experience in young fit patients, I fix them both and then they do well. So what do you do in patients with acute cuff tear with first-time dislocation? It is not uncommon in middle-aged or high-energy injuries. I've already said that. Investigate. And if confirmed with a scan, then you pre-rehab them. And then my clinical practice is I do operate when the shoulder is cold after pre-rehabilitation, and I do treat them both together at the same time. I would not necessarily treat very acutely because the stiff shoulder not necessarily gives us the best outcomes. I do give them a few sessions of physiotherapy, get the shoulder cold, calm it down, and then I go and repair after some time. Elderly and low sedentary patients, you can give a trial of non-operative treatment, but again, do not hesitate even in elderly patients to go ahead and repair if need be. So acute cuff tear with recurrent dislocation. again, suspect if it's highly unstable, suspect if the recovery is not the normal, suspect if it's the patient has been in a sling, gone on to do activities, rehabilitation, but still weak, then you suspect that there is an underlying rotator cuff tear. Then you do a scan, investigate, and treat both at the same time. Chronic cuff tear with acute or recurrent dislocation, we again alluded that in previously. In presence of underlying rotator cuff tear, the energy required is very minimal to dislocate the shoulder. Patient is young, fit, and do not hesitate to repair both at the same time. And its evidence is obvious that if we just stabilize, the outcome is not going to be good because the cuff tear is an important stabilizer. In presence of nerve injuries, in isolated axillary nerve injuries, I think there is no different to what we've discussed before. Treat as it is, not an axillary nerve injury, but you treat as it is. But in presence of a severe brachial plexus, I think it depends upon the severity, but at least you stabilize the shoulder, you wait for the nerve and to treat the nerve separately. I think that's the accepted norm in that one. So again, coming back to these three questions, have we answered these questions? When should a rotator cuff tear be suspected after dislocation? I think if a patient continues to have pain or develops weakness in our subsequent follow-up, you suspect that there is a rotator cuff tear. And if they do have both, whether you treat them operatively or non-operatively, I think most studies, at least in most clinical scenarios, they do better if you do surgery in the patients. And again, should you treat individually or together? I think the answer is if you're in there, the recovery is no different, especially in the cold shoulders, to do both at the same time, repair both rotator cuff and the labral at the same time, and rehab. And if you're lucky, you'll get the outcome as we just seen in a patient like that. I think that concludes my talk, and happy to take any questions from the audience.
Thank you, Dr. Bhuvan sir, for such a wonderful talk. It's an interesting topic, I think. Samantha sir, would you like to start with the discussion, please?
Yes. I'd love to join for the discussion, Karthik.
Yes, sir.
Because it is nice to hear from one of the masters in that subject. And the thing is that probably in India, we get the dislocated, the recurrent dislocated sort of patient with the calf injury. Probably not in the young group. Probably they are more or less like 40 plus 50. I think Karthik, Dr. Karthik and Dr. IPS will all agree that we may meet not the young guys. We usually see calf tear with the acute dislocated scenario. So whenever we see calf tears and probably some pathology in the anterior thing in the middle-aged group, we go ahead with only with the cup, but don't do something with the unless it is a frankly unstable. Do you agree, Dr. Bhuvan?
So again, I think that's completely acceptable. We're talking about the middle-aged or young patients.
Yeah. Because in India, you see that the contact sports like rugby and this polo, and where the real contact force is there, it is not been played. So the young group, the anterior dislocation, these are more or less low velocity sort of injuries that you people probably seeing in the rugby and the whatever polo and all this, with the young people having anterior dislocation with the cuff injury, probably more than 50%. But really that sort of scenario is we face in India. Mostly we see in the middle-aged group where it is calf is the more important component rather than the instability.
I think it's completely justifiable. I don't think anybody will disagree or argue with that. As we discussed, the main stabilizer is the rotator cuff. And it's acceptable to repair only the rotator cuff. But the evidence in literature, although is less, there is enough to say that to repair both at the same time, you are going to increase the conforming or the compression forces for the glenohumeral joint as well. So I think I'm in that where I have to repair the rotator cuff. My rehab is not going to be any different. You're going to put him in a sling for 4 to 5 weeks. You're going to rehab the same thing in any way. And if the labrum is off on arthroscopic examination, if it is medialized, if it is detached, then I would go and fix it at the same time. But if equally on probing, if the labrum is not medialized, if there is no false attachment, and if it is just a tear, and if it is not completely unstable, then I think you're absolutely justified to just repair the rotator cuff. I don't disagree with that at all.
Yeah, Bhuvan, I completely agreed on that point. Completely agree. But probably because the mode of injury and the level of the play is quite different from your whatever patients you are facing and we are facing, probably that might be the reason that we are not seeing such young guys having this recurrent dislocation or the acute dislocation along with the cuff.
Correct.
I completely agree with your thinking process and philosophy. I do agree that if both the components are there, it has to be, both the components has to be dealt with.
Yes. And also I agree that for us here, I'm not worried about the cost issue here. I don't mind whether to use speed bridge anchors or use the extra 3-4 anchors, because it's all insured cover. So I think, but I understand in some other part of India where it's not affordable, patients will not be happy to pay that much. But here, I don't think about that. So, and I don't mind putting, for 3-4 anchors to the labrum and then speed bridge on the rotator cuff. It's okay. But you're absolutely spot on. My patients in UAE, they're all high energy sports injuries. Before coming here in UK, my incidence of sports injuries was only 30%. Most of them were degenerative. And again, there my treatment was cuff. But in UAE, my sports injuries are 70-75%. Unbelievable sports injuries here. So it's changed my concept of rehabbing. Even rehab here, I go fairly aggressive here. Dubai, they can't live without working. If you don't work, you are deported. So I tell them to wear sling for 6 weeks, but they start driving from next day. I know I'm thinking, what was I doing in UK there? But here the rehab is good, the outcome is good. So I think it's changed my way of practicing here for the next step.
Thank you, Dr. Bhuvan. Thank you for your comments and nice thinking process. You are really straightforward in your answering things.
Thank you, sir.
Thank you, Samantha, sir. Bhuvan, sir, can I have a question?
Of course.
Yeah. We, as you rightly told, for the young individuals with maybe first time or just a second episode of dislocation, you put them on a rehab, they do well, you go for an MR just on the routine basis, you find a cuff tear, but clinically they are doing well. So in that case, in an young individual, so in that case, do you like to go ahead with the repair? Now, part 2 of the question, if you would like to go on a repair, what kind of tears on an MRI basis you would like to go for a repair? And does this decision making differ in a non-athlete and an athlete population? All these things in a patient who's doing good with rehab and he does not have any functional limitation.
If it's a question from you, I think it's an excellent question, but maybe next time I will present my another talk. It's on a very similar topic as well. So it's basically, we're talking about the size of the tear, the type of the tear in somebody who's dislocated.
Yes.
Let's forget the dislocation for a minute, and then let's only treat as a rotator cuff. Let's say partial rotator cuff tear. There's a 1/3 rule. 1/3 of the patients, they do better clinically, although the tear persists. 1/3 of the patients, the pain persists, the tear is same, and 1/3 of the patients, they progress to full thickness tear. So if there is a partial tear and a first-term dislocators, I will not, and if the patient is doing well, I would not treat them operatively. But if there is a full thickness tear of the supraspinatus, let's say you are 20-30 years, if there's a full thickness tear of the supraspinatus, 2.5 centimeters. Forget that he didn't have a dislocation. He just came with a 2.5 centimeters injury tear. So for the fact that this patient, after 5 years, after over a period of time, the tear is going to progress. And they retract very quickly. They retract very quickly because their forces are so high. They retract so quickly. And then when you go back, you will think, why did they not repair when it was fresh and acute? So to answer your question, partial tear dislocation, if the patient is doing good rehab, I will not interfere in that patient. But if there is a full thickness tear, I'll tell, look, there's a very high chance it is going to progress and it is going to dislocate again. So I would recommend still surgery, even though the patient is doing good rehab. Most of them will accept, some don't, but that's my logic.
Thank you, sir. So, a small extension to that, in the category A that you mentioned, partial tear people, non-operative, doing good with rehab. Let's take if he's not a normal guy and he's a contact sport athlete. Would your decision change?
If it is partial injury, especially if it is element intra-articular type 1 and type 2, there is an evidence that you treat them with the repair of the cuff, they do worse than surgery. So you don't touch them.
Thank you, sir. Thank you. So there's another question. It's actually my personal question. One of my patient, pretty known to me. She's around 50, late part of her 50s. She had a first dislocation, sent for an MR. So, you know, she had, I think it is kind of a chronic cuff tear. So the scenario was a complete supra-infra tear with grade 3 retraction, with of course Bankarts and so forth. Clinically, the patient, as of now, the reduction, I mean, the shoulder was reduced, stable as of now on rehab. Yes, she does have, it's a balanced shoulder in terms of cuff, not with the pseudopalsy kind of a picture, but she has some kind of deficits, of course. How do you recommend us to go across?
The question is it repairable or not?
Not ideally repairable. Not just with the repair. At least you need to go for a patch or some kind of SCR, something like that.
I think you answered your own question. So if it is not repairable, if the patient is doing reasonably well, leave her alone. If the patient has pain and weakness, then you're talking about augmentation, SCR. You know, it's a different myriad of treatment. Yes.
Yes, Dr. Bhuvan. Yes, I think I agree with it. Karthik's question. If she's not pseudo-paralytic and probably she's coping away with his day-to-day daily activities, if he's not pseudo-paralytic, I'm not going to intervene. Rather, I would stress upon on the rehab. And if it is not irreparable cuff tear, then probably I will rather go, if it is pseudo-paralytic sort of scenario, probably I'd rather put on with the tendon transfer rather than doing other things.
Yes, I mean, tendon transfers, I mean, I used to do before, but now I've gone away in tendon transfers.
Yeah.
Whatever, yes.
Whatever, because there are three options. Either you can go with your SCR or tendon transfer or the balloon. Whatever suits you best, that can be done. But this is only in the pseudo-paralytic scenario.
Correct. How is your experience in balloon? Just a diversion from the topic.
I don't accept the theory at all, even if it is going to be available in the market in India very recently. But I told that company I'm not going to use a single balloon in my career.
Okay. All right. Nice to hear that.
Thank you. Nice to hear too, Bhuvan, that you are on the same page.
I mean, the only time I've used balloon is to protect my repair, not as a supplement, not as a treatment on its own. So if I've done an SCR, if I want the repair to be intact, I've used it a few times in UK because it was available, not that because I wanted to do it. But I don't use it, sir.
Thank you.
Thank you, Samantha, sir, for the valuable input. Once there's a question from the audience. How much percentage of patients with first-time dislocators do you, in your personal experience, concomitant with RC tear?
Age.
They have not put it across, so let's say.
I think
that makes a sense. I mean,
it is age related. Yeah. The incidence is 7 to 32%, as I said, but it definitely proportionately increases after 40 years of age. So unless that's a high energy injury, I would say in somebody who is under 40, the incidence is less than 5%.
One question from me again, in going in for a labral work and a cuff work, how do you sequence it?
Labrum first. It's quick and fast, so then you do that.
Thank you, sir.
And also the space issue. Because if you don't want to injure your cuff once you have done it, then that's the best way of thinking is that you do your labrum first and the cuff second. So it makes more logical and your surgery becomes easy.
Yeah, I mean, for the cuff repair, you have to go into subacromial space.
Yeah, that's
usually.
why
and then you repair, then you try to put the scope in the glenohumeral joint after the cuff repair. It can be difficult. So
yes, that's why I'm agreeing that first the labrum, then the cuff. The surgery becomes easy.
Yes.
So there's a question from an audience, Dr. Vinay Pandey. It's a
Oh,
little
yes.
bit controversial. Few surgeons perform both surgeries in different positions, lateral and beach chair. How to go about in the same sitting?
Always a beacher. So
So,
I can tell you a little quote. I can tell you a little quote on that one. So I actually spent 4 weeks with Gary Gassman in Houston in 2007, and then he was very nice. On one particular day, he did 6 surgeries, 6 rotator cuff repairs, 6 different techniques, and then each technique was how he evolved over a period of his career. And then he said, if I have one time that I would go back and get my 15 years back, then I will tell, why did I waste my time in lateral decubitus? I wish I had done in beach chair. So, I mean, I have done my fellowship in lateral decubitus, but for me, it was, I could not get my head around, but somehow I've managed to do it in beach chair, both of them. And it's working okay in my hands. Sometimes I use Tremanos. If I have a good assistant, I don't. Otherwise, I'm a beach chair. So.
thank you, Bones. I completely agree with you. I'm a beach chair guy either. Samantha, sir, would you like to add on? You're a beach chair or?
No, I have tried both, and I have been nowadays. I'm completely 100% lateral.
Perfect. Perfect, sir. Perfect. Samantha, sir, would you like to add on to the anything from your side, sir?
You are asking me, Karthik?
No, yeah, for the discussion. Any question?
No, I have already discussed with you, and I've completely been happy how the way Dr. Bhuvan has put his topic, and he nice to see the patient's outcome also in 3.5 months' time, and how the rehab and all these things will go ahead with the cuff and this instability scenario. I think that was great to have interaction, even to see the patient's outcome at 3.5 months of time post-op.
Thank you.
This was this patient was very, classical. Usually you dislocate, they put back in the rehab, and they go back. But at this time, he would not. He had a different type of follow-up. I mean, he had an arm in sling. He went back. He had pain, night pain. You see him clinically. There is obvious weakness. I think this is the key to suspect when to suspect such injuries. I think that's the most important thing.
Once I have a question. Talking about we have already talked about the beautiful rehab that you have already done. What is your rehab protocol when you combine labral work with cuff work? Any difference, or you would like to
treat the cuff? Treat the cuff. Treat the cuff. Yes. So I used to be a very religious rehab protocol from shoulder dog and those kind of things. But then I have changed my rehab completely here. It's very, very patient oriented. So at 2 weeks, I divide the patient into normal pathway or accelerated pathway. So these patients, I put them into accelerated pathway because he's not stupid. I mean, he's very careful. He knows what to protect, but equally he will go for good full passive movements. And we have a gym in our own hospital facilities. So we have all closed loop chain exercises. So I think in this part of the world, in sports related injuries, I think they recover quickly. I mean, I'm not saying that you should be aggressive, but I think you should be cautiously aggressive. And I've seen in my recent IPL experience how these guys, they dislocate shoulder, no surgery, go back and bowl in 10 days time. So, there is that concept of, don't be stupid, but be cautious. And you can get an accelerated rehab. And if the patient, important thing is to identify a patient. Who is that patient? That's important. If I asked him a question, have you worn the sling in the nighttime for 3 weeks under every night? If the answer is yes, that means he's not stupid. I think they are the very good patients like
that. There's another question it's slightly away from the thing. What do you believe in the concept of biologics, using concomitant biologics injections? There was a question.
Happy to answer. In ICSS, I did present on the same thing. So many biological things. I think each one has different benefits in every conditions. If you divide this basically into high lace and those groups, or if cortisone injections, PRP, and then the stem cells, what we're coming at the end. Yeah, I think PRP is just an extended cortisone benefit. That's my clinical experience. And the stem cell biological supplements available at this moment of time, they are not differentiated. They're all undifferentiated stem cells, what's available in the market. They're not harvested, they're not cultured, they're not grown, but what's available is they're undifferentiated cells. So I'm not entirely convinced as yet, because they are still being tried in the equine stages, especially in the horses, where the tender flexor tendons are they're being still tried in that one. There is one good South Korean paper, but only 6 patients in partial rotator cuff tears where the stem cells have shown some benefit. So I will have my reservations on saying that the stem cells or the healing factors and all that. Having said that, there are some papers to say that PRP injection after the rotator cuff repair, you inject on top of the rotator cuff, they give a better results. And I rest my hand. I don't know how the fluid will stay in the tendons after you repair. I think it's just going to dissipate with the fluid in that one. So I think I don't know. I'm not a firm believer in that one.
Thank you, sir. IPS sir, would you like to add some fire on to the discussion? We are almost there on the. We welcome you back from Jharkhand.
Yeah, I just finished the Jharkhand, so I'm honestly not aware of what fire has already been put here.
There's a lot of been discussions on instability in this thing, so we would like.
Yeah, just wondering. I mean, just question out of my curiosity: how much of stiffness or a stiff joint would you accept in a patient? Because these patients tend to become a bit more stiffer. So, how do you? Is there a way to assess that these are the patients who would do well, and these are patients where probably you should do just one of these 2 pathologies?
See, in my experience, there has not been any increased stiffness if I do just a stabilization or both together. And I think a well pre-rehab patient prior to the surgery is the key. I would very, very rarely, I would go and do within 4 weeks after the injury. I think there is evidence clearly that in presence of pre-existing arthrofibrosis, they don't do as well. And the answer to your question, how much stiffness would I expect? I think I'm a typical example. I have external rotation of 90 on my right side, and I have only 60 on the left side. And I have no issues in performing any of my sporting activities. I think if I get 70 degrees of external rotation, loss of 20 degrees, and if I get full flexion, full abduction, and loss of 10 to 20 degrees of internal rotation, I think that's a good outcomes.
And does the technique also make a difference? So if you are actually going in for a double row cuff repair along with instability surgery, you can actually aggressively rehab. Does that also make any difference?
We just touched on that. I think definitely accelerated rehab in some particular patients, identifying those group of patients, they do recover very quickly. Yes.
When we do have a cuff tear along with instability, how often have you seen a bony lesion like a bony Bankart in these patients? And would your management actually change?
There is 1 or 2 with the isolated bony Bankarts, but fortunately the bony Bankarts was not big enough to be worried about. So you would treat that bony Bankarts as a soft tissue Bankart lesion, and that would not change my management. Yes, if you're asking me what do you do with the big heel sacks and a big bony Bankarts and in presence of rotator cuff tear, I think that's a difficult challenge. And I think you should treat as you would treat instability, maybe a lethargy or maybe a remiplacage, along with the labral repair and the supraspinatus repair as well. Yes, I would treat as the pathology dictates.
Okay. Machani, just one last question. Sometimes patients come with an instability, and he's a young guy, and there is very well documented Bankart tear, but there is also a partial articular surface cuff tear. Would you actually address to those kind of pasta lesions, or you think the main problem are Bankart and let's just do it and maybe leave the pasta like it is there?
I think Karthik has been ahead of you in this game, so we just answered that question.
Yeah, just answered it. I just missed it because I was
slightly. So partial articular, I would treat only instability, especially if they're doing. Yes.
Perfect. I think that answers our question.
Can I have one last question from my?
Yeah, sure.
You can.
Yeah. So as you already enlightened about the GT avulsion, you talked about the displacements and things. What is your preferred technique of fixation?
For the great tuberosity?
Yes.
Okay, so you might be surprised if it's a big fragment. If it's a big fragment, I like filer split.
Oh,
You'll be surprised, isn't it?
so that
Because
is the real fire.
it is a real fire. I wouldn't go on to that one. Why? I've used screws. You will never sleep well with that one. I just like to get the sutures around the tendon into the filers, and I put the plate so low just as a buttress, and then it's a fire. But I prefer that rather than two compression screws or anchors. If I can't use a filer split, if the fragments and all that, I use a lot of intraosseous sutures. I put two anchors in the bed of the humerus, and then get sutures to the tuberosity, and then tie them back onto that one. So I don't mind doing that. But if it's a big tuberosity fracture fragment, I treat them with one nice filer split so that they can rehab very quickly.
That's a good one. Thank you, sir. Thank you. And just one last, slightly deviated. Do you believe on the concept of double row repair? I mean, double layer repair in the laminated tears, or you really do not?
Karthik, you are opening a Pandora's box now.
Since it's the last webinar.
Okay.
Yeah.
We can discuss this. No, I will. My preferred technique is a single layer for a laminated tear. So.
Thank you, sir.
Yeah. It's just being more and more anchors and more problems, I think so. Good.
Thank you, sir. Thank you so much.
Thank you very much.
So much.
Thank you very much indeed.
Thank you. Pleasure to be here. Thank you so much.
Indian Arthroscopy Society would definitely have become wiser today evening by listening to your thoughts, and then good discussions by Karthik and Dr. Samantha over your talk. So nice to have you here on Indian Arthroscopy Society webinar, and we indeed are honored to have you here and sharing your thoughts today evening. Thank you very much, sir. Have a nice day and take care.
Thank you. Good night to you all. Thank you.
Thank you.